appreciate all of you for joining me in this webinar. We are going to discuss about peri-implant tissue stability and some of the factors related. I know that all of you have put a good day's work in, so thank you all for joining. I hope this will be clinically relevant for you. Just as a disclosure, I do have a speaking arrangement with BioHorizons, and I receive honorarium for my lecture. I try to be very objective, and I also direct the Vista Institute. So I do have some conflicts of interest that I'd like to always share, but there is always going to be objectivity. So as clinicians, there's nothing more important to us than having a stable outcome for whatever treatment we're delivering for our patients. Patients pay us and compensate us for care, and they expect to have something that lasts. So in order for us to make our treatments that are enduring, we need to pay attention to some of the factors that are important for the stability of the peri-implant tissues. So I have basically divided the factors that can lead to peri-implant bone loss into patient-specific factors, surgical factors, prosthetic factors, and biomechanical factors. We're not going to discuss every factor, but I'd like to hit on some of the key points. These include peri-implant mucosal phenotype, peri-implant bone phenotype, and some of the other factors such as history of periodontal disease or hygiene, systemic conditions, and so on. The surgical factors are important regarding the implant position, the 3D position of the implant within the bone, as well as how the surgery is performed, whether it is overheating or over-torquing or graft failures, or poor management of the flap and so on. Frank Renoir, if you know him, is a surgeon in France. He has come up with this idea called human factor. If any of you have ever read any of his publications, very important to, he points out that many of the, poor outcomes originate from errors, human errors that could be avoidable. So we like to, try to understand better these factors and try to improve upon them. Prosthetic factors also include abutment design, prosthetic design, very broadly. We'll touch upon that. Biomechanical factors are important, and we're going to also touch on about the implant abutment design and many other aspects that we just simply won't be able to cover here. So let's talk about the peri-implant tissues. When it comes to teeth, we have periodontal phenotype, that basically the physical characteristics of the periodontal tissues. We have similarly peri-implant phenotypes that include the thickness of the mucosa, whether or not the surface tissue has keratinization, and also the alveolar bone thickness. So the peri-implant phenotype is really, really important to understand and know that it's one of the determinants of the tissue stability. So as a kind of a marker for peri-implant tissues, one of the things that has been measured has been abutment height. Now, why would abutment height be important? Because it indirectly relates to mucosal thickness. When you have thick mucosa, you use long abutments. When you have thin mucosa, you would use shorter abutments. So studies have shown that when short abutments are used, very much more bone loss. When longer abutments are used, the bone is much more stable. So you can see that, especially with 1 millimeter abutment, okay, 1.2 millimeters of bone loss, 2 millimeter, 1.2 millimeter, but then with 3 and 4 millimeter, far less bone loss, but it's very consistent over a 2-year period that longer abutments have more stability. And this has also been shown for full arch reconstructions. And this has been demonstrated that, especially when the abutment height is 1 millimeter, you could see many cases of 3 to 4 millimeters of bone loss, 2 to 3 millimeters of bone loss. 2 millimeters still has some of the sites that have 2 millimeters of bone loss. But then when the abutment height gets to be higher than 2, there's very little bone loss. So abutment height seems to be very important, and this has been correlated with the tissue thickness. So in this study, they measured the tissue thickness both, actually with the perineal probe as well as a ultrasonic, and they did find that the tissue thickness is very important and relates to the stability of the bone. The other factor that seems to be very important is the 3D positioning of the implant. So if the implant is placed subcrestal or ecocrestal at the same level as the bone, what they find is that when the implant is placed subcrestal, the bone is much more stable. You can see that over time, subcrestal has stability, equicrestal starts losing bone. Okay, and you can see in this follow-up of 5-year study, equicrestal placement, significant bone loss, subcrestal bone placement of the implants, very stable bone. So this is a very important factor that it's taken us a while to recognize that implants should be placed subcrestally. But part of the reason that this hasn't caught on because some of the earlier design implants are really not appropriate for subcrestal placement. You can't put an implant that has leakage at the implant abutment junction subcrestally. So we'll talk more about that. So you shouldn't submerge or place every kind of implant subcrestal. Typically, you want to place an implant subcrestal that has a very stable implant abutment connection. More about that. But you can see that equicrestal, many of the sites have bone loss. Subcrestal, almost no bone loss. And that's really quite remarkable. So that's one thing that we should address very much in our protocol, is to understand that equicrestal, when you place an implant at the same level of the bone, you're going to get bone loss. Subcrestal placement will have bone stability. Why is it? Because there's always going to be some remodeling around the implant. And when there's remodeling, if it exposes that rough surface of the implant initially to the oral environment, that can initiate marginal bone loss. So it's really important that we don't allow any opportunity of exposure of rough surface of implants to the oral environment from the beginning, because that could be the initiation of peri-implant bone loss. So subcrestal is what we need to do, but it should be a very stable implant abutment junction. This is a study that, again, emphasizes the importance of thick bone phenotype, very, very stable bone, thin mucosal phenotype versus thick mucosa. Thin mucosa, 2 millimeters of bone loss. Thick mucosa, almost no bone loss. So the thickness of the mucosa is also very important. So I should say here is that when you place an implant subcrestally, right? What you're doing yourself is creating thick mucosa. You could see that by subcrestal implant placement, you're actually creating thicker mucosa because that marginal bone that remodels, it's not bone loss, it's remodeling, leads to thicker mucosa. So just keep that in mind. When you have thin mucosa, it's prudent to place the implant a little bit deeper. You can actually, even without soft tissue grafting, increase automatically the thickness of the mucosa, recognizing that thick mucosa is very stable. Now, I alluded to the fact that there are, some implant abutment connections that have more leakage than others. What are those? There are two kinds of connections between implant and abutment. Some that are butt joint, means that you have a flat top of the implant and you have a flat abutment, and when the two come together, it's a flat to flat connection. Then you have a conical connection. So if you have two flat surfaces that are meeting, a butt joint connection versus a conical connection, a cone in cone connection, these are very different and they behave differently. These two gentlemen, Paul Weigel and Holger Zipprich, they're from University of Frankfurt, and they've done some very interesting studies to visually illustrate differences in these types of connections. So if you have a butt joint connection, you have two flat surfaces that are against each other. They did radiographic video on that to show that when they subjected to lateral forces, you can see a micro gap opening up. Let's watch it again. When you apply force, you can see a big micro gap can open up, and you can imagine that opening can allow lots of bacteria to enter in. So you see that micro gap opening could be a problem of flat to flat connection. So let's look at this. When you have butt joint implant abutment, the top of the implant is flat and the walls, the internal walls are flat. So when the abutment seats inside of that, there has to be a fit, some kind of a space to allow the abutment to be seated. In contrast, for conical connection, you have a cone in cone connection. So for butt joint implants designs, there has to be a clearance fit. Means that you have to have a cylinder in a cylinder, right? And there has to be a clearance for a cylinder to fit inside of another cylinder. So it has to be a space there. In contrast, a cone in cone or conical connection, you can have a friction fit so that you can visually see that is a much more secure fit. The other thing is that when you apply load to the butt joints, you can see that you can displace that abutment, and that could open up a gap to allow the bacteria come in, versus when you have friction fit connection, there is no joint that opens up. If you think of it, when you stack some glasses together after washing them, it's going to be very hard to pry them apart because you have that cone in cone connection. Now, this degree of taper of the internal component of the implant abutment is also very important. And the length of these connection is very important. If the degree of taper is too little, it's going to be almost impossible to get this out. And when you place this abutment in, it actually causes deformation of the implant and can distort the implant. So there's a sweet spot. So I will tell you what that sweet spot is in a few minutes. So does that happen just, theoretically, or do we see that? This is actually one of my patients. These implants I placed maybe 20 years ago, and I was very unhappy when after a year, the patient came back from the restorative doctor's office and this is the condition. You can see there's been a great deal of leakage. This is a flat top implant. You see that these are flat, and that junction has not been stable, allowing the biofilm to infiltrate that area, causing great deal of inflammation. What I like you to particularly pay attention is the wear that you see on the surface of the platform. This is called fretting. This kind of fretting or wear can basically show that there was a lot of motion in this area, wasn't stable, and that's basically allowing the bacteria to cause inflammation. But one other thing that we become aware of is that this kind of a metal on metal is very similar to what's happening around the prosthetic hips. And the prosthetic hips, it's been known that there's a phenomenon called metallosis, that these small titanium particles that are released into the tissue are encapsulated and phagocytized by phagocytes in the tissue, causing lots of inflammation and lead to failure of many of these prosthetic joints. So we become aware that the same thing could happen to implants, causing peri-implantitis, but by releasing these very small titanium particles. So it's really, really important to have a very stable implant abutment connection to avoid this kind of a metal on metal grinding that could lead to this metallosis phenomenon. So the other aspect that I like you to consider is the length of that conical connection. So you can see that this is a conical connection with 8 degrees of Morse taper and a butt joint connection. So you see that when you have a conical connection, when you subject that to off-axial loading, there's very good distribution. But then when you have a butt joint connection, you see the opening. This is finite element analysis, mathematical engineering kind of illustration, and you see excess load building up at the junction. So this is very much also been demonstrated by a mathematical model of finite element analysis. So for the past few years, I've been using this particular implant, the ConeLock Progressive, and I've been very happy because this is a conical connection implant, a deep conical connection implant that has produced very good results in my clinical practice. So I've been very happy with that. I'll show you a few clinical cases. Here's a patient with a high aesthetic demand. She has veneers and crowns on all her maxillary teeth. And one of those teeth, tooth number 9, has to be extracted due to endodontic lesion around the area. And you could see that there's apical resorption of the root. So I'll illustrate to you all how we manage this patient. And you could see that there's a very thin bone phenotype. The buccal bone is very thin. So you know that when the bone phenotype is thin, it has high propensity for resorption. So the tissue doesn't have probing, so the facial bone is intact. There's no dehiscence. Very much removing the crown very carefully. Then we're going to do a socket shield to just basically erode most of the tooth structure, starting with a diamond and then diamond burr, and then going with piezo surgery to reduce more and more of it. And then we're performing osteotomy, okay, to perform the implant site preparation. I'm also performing a VISTA, vestibular incision, subperiosteal tunneling. This is a ConeLock Progressive surgical kit. This is a guided kit, and this is one of the first ones that I use that has a kind of a no keyless kind of a guide, which is very nice. Then we make in place the implant, very stable implant placement, and then making immediate and grafting around there, making immediate provisional. And you can see that this is the provisional. Then this is the final, and very stable tissue, and we're able to match the contralateral tooth very well. So I've been very happy with this particular implant for the last few years, but I'll show you progression of that to you can see the stability of the bone around this area with the that particular socket shield technique. I've also used this implant for immediate molar. So I'll show you the technique that I use for immediate molar situation, that we are basically finding that because of the divergence of the roots, we're able to place an implant in the furcation area. And there's adequate bone. I don't go for a super wide or super long implant. So we start by performing the osteotomy right through the furcation of the tooth. You may ask why through the furcation of the tooth? Because the osteotomy is guided by the roots. Because if you extract first, that septum, interradicular septum, is going to be destroyed by the drilling process. But once you perform all your osteotomy through the furcation, those roots will keep the drill right in that furca and protect that septal bone. So then you'll be able to extract the tooth after the osteotomy. And you can see that very careful extraction of the remaining portion of the root. And there's very good osteotomy already performed and finalized. So the implant is placed right through the osteotomy site, through the socket. You see that as it was planned in the CBCT, right in the center of the socket. So the osteotomy is very well produced. Then after implant placement, grafting around there. Now, this particular implant had a fixture mount. And that, for me, is one of the things that I wasn't as excited about. Having a fixture mount, many implant systems today have that fixture mount. And I'll show you the newer design that is a mountless type of a implant placement. So I'm grafting around the socket, around the implant, into this area, creating a little bit of a tunneling, and then placing the PRF to try to close the socket access, and by placing mattress sutures and protecting the graft, and then waiting about 3 months for the loading. You see both implants look pretty good. Then when it comes to the restoration, I like this kind of a restoration that is kind of a screw-mentable. I have this done by Vulcan. You can see that they designed the abutment and the crown, and I would have them at 2 separate custom abutment plus a zirconia restoration with a screw access hole. And I like to cement this intraorally, okay? So you see that these are screw-mentable restorations, 2 separate pieces that are not cemented extraorally, because if you extraorally cement, it may be, the contact may prevent you from seating it fully, and you may have non-fully seated. So the screw access hole will give you access if you ever need to remove the restoration for any reason. So you could see that on the day of delivery, we're removing the healing abutments. we would flush out the inside with betadine. You see that with the conical connection implant, you can see there are 3 cams inside this cone-like implant. So you can see the abutments in 3 different positions. So the tissues are very healthy because of that conical connection. I irrigate that with betadine and then seating the abutment and torquing the abutment. So this is the key. That's why I like having separate pieces, because I can always be sure that abutment seated and torqued all the way to what is need to be torqued, okay? And have 100% assurance of the abutment seating. And then we will fill the access with Teflon tape and then cement the crown with either temporary or permanent cement. And then the good thing is that when you have that screw access, that serves as a vent. So any excess cement will come out of the occlusal and not go down into the pocket. So here is a sequence. You see osteotomy performed through the FERCA, implants placed, and custom abutments made with custom crown. Now, one thing that I like you to see, differences in the 2 sides. You see that on one side, the implant is not quite as deep, on the other side is deeper. But what this leads to is a different angle of the abutment on one side than the other. So we are kind of repeating the experiment that I showed to you inadvertently. So perhaps I should have placed his right implant a little deeper, and that way the angle of the abutment would not be quite as steep. And I will explain what is the difference. So you see, when the angle of the abutment is more than 30 degrees, studies have shown that there's more bone loss. And there's also, you can see that when the angle of the abutment is too steep like that, then it limits the soft tissue thickness around the area. Versus if the angle of the abutment is more acute, then there's more room for the soft tissues in the peri-implant areas. Now consider then also placing subcrestal implant positioning. So you can imagine that you have much thicker and longer mucosa in this area. So this is an optimum situation to place the implant deeper and also design the abutment with more acute angle and not more than 30 degrees. That's very important. Then if you have an implant abutment connection, that's conical connection, that is going to allow for the stability of this junction between the implant abutment that is placed subcrestally. Okay, that will lead to the most stability. So you can see the different situations when the angle of the abutment is too wide, more than 30 degrees, you have the thinner tissues and the less angle with the abutment, especially with subcrestal positioning and conical connection, then you have the most optimum peri-implant bone and tissues. So for the last few years, I've done a lot of these cone log implants, and I've been very pleased with the outcomes of these. And I've done a lot of full arch cases as well. Now, I'm very excited that recently the tapered pro conical implant was introduced that has some advantages over that conical connection cone log implant. So you could see that this implant has a very deep conical connection, and that allows one to design the abutments that have the implants to be placed subcrestally, and the abutments to have a more acute angle and not have too divergent of an angle. So the deep conical connection is very important for the stability of the peri-implant tissues, stability of the implant abutment junction to allow subcrestal positioning. Now, this implant, unlike the cone lock, has 6 cams. You saw that the cone lock has only 3 cams. This becomes in very handy if you have especially some angled abutments that you're using, then you have 6 positions. When you're using custom abutment, it doesn't really matter. But when you, especially for full arch situations, when you have the angled multi-unit abutments, you won't have to have A and B, 2 different types of angles, because if you have limited number of cams, you have to have A and B, one that turns towards the direction of the implant, one abutment that goes away from the implant. With this 6 cam positions, you don't need A and B multi-unit abutment. So this makes it very convenient. Another thing that BioHorizons has done a great deal of research over the years has been the laser lock treatment of the coronal portion of the implant. And the laser lock leads to functionally oriented tissues. So this is really important to have that laser lock treatment right at the crestal portion. The other thing that I'm very happy with as a clinician, I prefer the mountless uh, implant drivers that go directly into the implant. And because these implants are grade 5 titanium alloy, they're stronger. So there's no chance of damaging the internal components of the implant through the insertion process without the mount. So this implant has only been out a few weeks. I've already done a variety of different cases. I'd like to share my experience with a few of these such cases. This is a patient who actually flew in from out of town, who has a local general dentist who has been treating him for many years. And these 2 teeth have become non-restorable because of his caries-prone condition. The restorative doctor preferred to have these extracted and implants placed. So one of the things that I like to do is to make sure that we have adequate distance between the implant and the socket wall. We like to have 3 millimeters or more, or 2 millimeters is the minimum, but 3 millimeters in this case we were able to achieve. And we have, relative to the bone crest, about 4 millimeters to the mucosal junction, which will give us enough room for emergence profile and also for the final implant to be slightly subcrestal. For that reason, I selected a narrow implant. This is a 3.8 millimeter diameter implant. So extracted these teeth very carefully without damage the peri-implant tissues or bone. So the bone was very stable. So one of the characteristics of the this tapered proconical is this reverse buttress thread design that gives a very nice primary stability to be able to engage the socket wall and the palatal aspect to have very stable implant primary stability. As you could see, that there's a sufficient gap between the implant and the socket wall, at least 3 millimeters. And you can see the 6 cams of this particular implant. I also, because the patient is flying in from out of town, I went ahead and scanned the patient just so next time he comes into town, the restoration will be ready to go. We don't have to wait for that. That's a really nice feature to have this type of a scan bodies, especially these metallic scan bodies are very nice. We scanned and then put 2 titanium temporary abutments, relined a provisional shell that the patient had, and then packing some particular graft that was made into sticky bone. This is mineros corticocancellous bone that was made into sticky bone with liquid PRF packed around the implant, and then placing some solid matrix PRF, LPRF, in the tissue zone. I don't believe in the concept of placing graft in the tissue zone. I'd like to place the PRF in the tissue zone to accelerate the tissue healing. And you can see this is screw retain restoration for the provisionalization. And then the patient had to go back home. But in the next few days, it's after 5 days, when he came in for follow-up check, you can see that the tissue have healed very nicely and very quickly. And here he is. This is a more challenging situation where the patient had a significant bone loss around the tooth that had fractured, and there was dehiscence on the facial because there was 13 mm pocket, and clearly the buccal wall was missing here. In the past, I would not place immediate implant in these situations, but we are very confident that we were able to get good primary coverage. So in this case, I'm making VISTA, vestibular incision, subperiosteal tunneling, to expose the dehiscence and to be able to graft around it. You have to obviously be careful of the mental foramen, which is right here. So we go in the direction of a crestal, and you can see that the tooth was clearly split. Through that vestibular access, we can visualize that the dehiscence, placing an immediate implant with good stability. It's really important that the implant is placed as far lingually as possible. In this case, we had more than 4 mm of gap. And then the implant is in good position. You can visualize the dehiscence and the exposed implants. We're able to place a striate collagen membrane through the vestibular access, placing the sticky bone inside the socket, as well as from the vestibular zone, to make sure that dehiscence is fully covered with a particular graft. The membrane is positioned, and then placing some PRF for enhanced tissue healing in this area. And you see that this is the grafted area. And within a week here, when she came back, you could see very quick healing. So the benefit of using a vestibular access is that I was able to overgraft this area and make sure that dehiscence is fully grafted and the implant is far away from that, but we didn't have to reflect the papillae or making a crestal incision, so much faster healing. Now, every now and then, when patients come in this kind of condition, I shake my head. This is a patient who came in a couple of years ago with caries and severe periodontal disease, all this calculus, and the dentist had just placed an implant in there. Now, mind you that the implant next to it had 10 mm pockets and almost bone loss to the apex, and the dentist just placed an implant right next to it. Just basically, it makes you shake your head to think, what are they thinking about? Or maybe not thinking. So you can see all this calculus. So one of the other factors that I wanted to point out to you is bacteria, and this could be the initiation of periodontitis, peri-implantitis. So patients who have history of periodontal disease are much more prone to peri-implantitis, so we need to treat their periodontal disease first. So in this patient, we treated his periodontal disease in the mandible. We extracted the maxilla. You could see the amount of bone loss around his implants and the caries. So we did a full arch. So these are cone log implants. This is what I was talking to you about. that when you have these tilted implants and you have angled abutments, having only 3 cams with the previous design meant that we may have to have A and B. This happens to be an A, and sometimes yeah, I would have to use a B. But in this case, we were able to get this in. And then this is the prototype. And you see it's very healthy now because we took the time to treat his periodontal disease. And this is the prototype. And this is the final restoration. So we kept all his mandibular teeth, treated the periodontal disease. He's a new man. He really has meticulous oral hygiene. He's lost weight. We did clear aligner ortho on him, and you see that the lingual wire that was placed in, he is really turned around. So it is possible to treat someone with periodontitis with full arch implants or individual implants, but we need to treat the periodontologist first and to really educate the patient about the oral hygiene and the importance of that. So you can see I use a short implant posteriorly and tilted implant anteriorly. Now, I want to show you for the last case, my first opportunity to place the full arch with the new Taper Pro conical implant and some of the advantages of that. We had a course on full arch implant at the Vista Institute last weekend. So this was a live surgery patient for that course. The patient had lost vertical dimension. So we took a CBCT with a fiduciary for dynamic navigation surgery. So I'll show you how we did the surgery. First, we had done the digital design so we could actually superimpose the digital design of the restoration into this area. So when I did the planning in the navigation surgery, it was actually incorporating the digital design of the restoration. So I'll show you how this works, placing these trackers in to be able to do the navigation surgery, doing a flap. And then this is the Tapered Pro kit, which is very nice. There are only three drilling. You see that you have the pilot drill, and then you have the soft bone drill and the final drill. So only 3 drills for each implant for dense bone. So you see with the navigation, you're calibrating the drill. So I'm not looking at the patient at all. I'm looking at the screen, trying to achieve bullseye. And you can see that we imported the digital design of the restoration. So as I'm drilling right into the central fossa of the eventual restoration. And you see with the tilting, I'm fully tracking the position of the drill as it goes in the panoramic, in the sagittal views, and making sure that the osteotomy is performed adequately. Then we are attaching a different tracker because we're going to extract all the teeth. This is a bone-supported tracker. And then you see that we're placing implants. First, we calibrate the implant, and then we are placing the implants with a new tracking, and we can see our drilling, osteotomy, and making sure that we have the bullseye to be in good position. So this is the very convenient drilling system osteotomy with initial 2mm pilot. And then you have a soft bone, and you see that these are step drills. And then there's a dense bone drill for every size of osteotomy. Very convenient with this Taper Pro conical. And these are the implants. You see the mountless driver. So as we're placing them, you see that very nice primary stability for immediate loading. This one I had to prep a little bit more. And then after placing the implants, we're placing the multi-unit abutments. The multi-unit abutments, for those of you who have not used the system, are really beautiful. They're very low profile. You see that they have a very nice kind of a trumpet shaped contour to allow much thicker tissue around them. They're really very nice design. So we use 3 mm MUAs, and then this is a MUA guide, multi-unit guide. We torque these abutments. The torque for this implant is only 20 newtons because the friction fit of the implant abutment is so stable that you don't need a high degree of torque. And you see that after putting in the multi-units, we put healing caps, and then we are basically doing a wash with those with a bite registration material, okay, to capture the bite and the vertical. And then we will scan intraorally the multi-unit abutment guide that was placed and register the bite with that. Then we remove that and we do photogrammetry. This is an extraoral scanner that we scan these implants so they very quickly scan the implant position. After that, we will suture the patient and scan the tissues intraorally with the intraoral camera. And you see, these are the implants. These are the taper pro conical implants. We did bone resection to make sure that we have wide enough bone. Implants are subcrestally positioned. All of them, you see, just a millimeter, millimeter and a half subcrestal positioning. And these are the 4 implants in position. So you see that we had the upper prosthesis, we had the multi-unit abutment guide, and the prosthetic positioning guide. This way, when we place the multi-units, we're sure that the position of those multi-units are in correct position. Then we do a wash. First, we do a photogrammetry to capture the implant position. Then we do this wash to capture the bite registration of the patient. And then very quickly, the lab will provide us with a digital design of the prosthesis. And we take that digital design and 3D print it in our sprint ray that's in our office. And within a couple of hours, the immediate load prosthesis is delivered. And here's the patient a few days later, like I think 5 days later, for post-op check, you see nice healing of the tissue. So in altogether, I think this has been a significant advancement in the implant design. I'm really excited about it. So I think we're right on time to discuss our take-home messages for this evening. Peri-implant mucosal thickness is very important. We need to pay attention to that. And patients who have thin mucosa, we may need to do soft tissue grafting. This is something that we didn't discuss. But if you place the implant subcrestally, it virtually does the same thing as thickening the mucosa. The abutment height as a measure of tissue thickness is inversely correlated with marginal bone loss. So if you're using a short abutment, it's not a good idea because there's not enough room for the biological width to establish itself. But also, you want to place the implant subcrestally. That increases the abutment height, that increases the tissue thickness, and it avoids having exposure of the rough surface of the implant to the oral environment. But keep in mind, you cannot put subcrestally just any kind of implant. It has to be implants that have specific quality, especially they need to have a conical connection. So in my experience, using a Taper Pro conical implant has had a number of advantages, such as a very deep conical connection, and the laser lock to give functionally oriented tissues around the area. Having the 6 cam is very convenient, especially for these full arch cases if using tilted implants. And the primary stability of this particular implant is very nice with a reverse buttress thread design, allowing us to be able to achieve a immediate implant placement primary stability that's adequate for immediate loading or immediate provisionalization. With that, I'd like to thank all of you for your attention, and I hope this has been clinically relevant for you. I see there are some Q&A questions here. The unknown participant has a question. What is the force-looking tool that you're using for placing bone graft? Oh, the bone packer that I was using is from Lachelle. It's a two-piece that opens up, and you can place the graft and pass that through that. So it's from Lachelle. How these subcrestal? Subcrestal placement, in my view, depends on a number of factors. One is that you have to consider the thickness of the mucosa. If you have thin mucosa, you want to place the implant a little more subcrestally, maybe 2 millimeters subcrestally. If you have thicker mucosa, maybe, and thicker bone, maybe 1 millimeter subcrestally. The other consideration is that if you have adjacent implants, you don't want to place the implants at too much of a discrepancy, because we did actually a study before that has been submitted for publication, that if the implants have vertical discrepancy to adjacent ones, the one that is submerged more is more stable. The supracrestal one usually loses bone. So make sure if you're sinking the implant subcrestally, it doesn't create a discrepancy with an adjacent implant. Okay, so I guess this one related to the forceps that was used, so I answer that. Any other questions? Okay, and do you like taller healing abutments also? Yes, healing abutments also should be taller if you can basically can accommodate them under prosthesis. It should basically be consistent uh, with the depth of the implant. So if you have a deeper implant, you may need to use so I often use 6 millimeter healing abutments for these implants that are subcrestally positioned. Do you always cover the cover screw with bone graft? Healing abutments cutting through the bone. Upon placing healing abutment, are you cutting through bone? Yes. So if I'm placing immediate implants into molar, I usually like to submerge them, and I do like to have a little bit of bone on top of it, because ideally you want to have subcrestal implant positioning when it all heals. So yes, I use a bone profiler to prepare the implants when I do a second phase. So bone profiler is a very nice tool that you can actually place a protector, and it's kind of like a Trefon-like device that gives you just the right amount of bone removal to give you the ability to seat your prosthetic component. So it is useful to have the cover screw and put graft around it to be able to achieve subcrestal position of the implant after the healing. Did you do the dentist who had the calculus? Okay, I have same experience. Well, the thing is that when the patient presented with all that calculus on the teeth, I generally don't like to throw other colleagues under the bus. Of course, my number one commitment is to my patient. I don't like to inflame patients. I don't like to just say, harsh things about other colleagues, because I don't know the circumstances that happen. All I can advise the patient what is in their best interest from today on. So I basically advise that it's not in the best interest to proceed with more implants until the periodontal disease is treated. They need to have all, because you don't want to take a patient with all that calculus. And even if you're going to be extracting all the teeth, I like to put them through a maintenance regimen. I like to have them spend some time with a hygienist to be educated. And as a test, if a patient is unwilling or unable to perform oral hygiene, I'm not going to do a full arch reconstruction on them because it's going to set them up for failure. So it's really important to take that time initially to educate the patient and basically take them through a process of decontaminating the oral cavity, reducing the bacterial load before you take them into surgery. So I hope that the information that I provided to you will be clinically relevant for you, and you continue to pursue this line. And the information that I share with you, you can do further reading and information about that. So you can incorporate that into your clinical practice. Some people will say it's possible to completely avoid bone loss. It's not, because we can always try to aim for minimizing that by taking into account all the factors that we can control within our uh, level of control. So with that, if there are no other question, I want to thank our host from Catapult Education, and I hope you found this information useful for you.